Good afternoon. Salam alaikum to everyone. I'd like to take a moment to welcome you all for taking the time out of your busy schedules to join us on what I think is going to be a very important topic for discussion this evening. My name is Ravi Mamtani. I am a professor and vice dean at Weil-Cornell Medicine in Qatar. Now, as a reminder, I know that many of you have attended these webinars before, but as a reminder, the objectives of the Population Health and Wellbeing series are: number one, discuss contemporary and critical topics relevant to healthcare, medicine, and population health. Examine evidence-based practices germane to public health and patient care. And finally, describe opportunities and challenges in the evolving face of healthcare and population health. Before we get into the seminar, some housekeeping notes. Your cameras and microphones are turned off. Use the Q&A feature to type questions and comments. And questions will be addressed at the end of the session. I will moderate the session. Any questions and comments, I will read them and present them to our expert this evening. As you all know, that this activity is accredited. It's accredited by the U.S. Accreditation Council for Continuing Medical Education and also by the Ministry of Public Health here in Qatar, and it's approved for a maximum of 1 hour of CME activity. The evaluation certificates, just a couple of comments on them. The post-activity evaluation will be available in your Cloud CME account by March the 20th. You will receive an email notification once the evaluation is available in your Cloud CME account. And finally, your certificates will be available for download once you complete the post-activity evaluation on the Cloud CME portal. So now on to the seminar. Today's topic, as can be seen, is entitled Panorama of Lifestyle Medicine, including upstream determinants of health. And our guest this evening to present this topic is a colleague, a friend, and a fantastic speaker who is well known in the field of lifestyle medicine worldwide. And I'd like to take a moment to introduce our speaker, Dr. Rob Lawson, who's the chair of the British Society of Lifestyle Medicine and also the chair of the World Lifestyle Medicine Council. Having qualified in medicine in 1975, Dr. Lawson has gained extensive experience as a general practitioner in Scotland, United Kingdom. His principal interests have been primary and secondary prevention of disease and the specialty of lifestyle medicine, as well as leading his National Health Service team to the highest awards for quality in the period 2003-2013. He founded a charity in 1991 providing weekly activity and support in the county of East Lothian for people living with long-term conditions such as heart disease, diabetes, stroke, lung disease, and frailty. He has recently retired from clinical practice to concentrate on the applications of lifestyle medicine to healthcare. In 2016, he co-founded the British Society of Lifestyle Medicine, a registered charity to promote the principles of lifestyle medicine to healthcare professionals and the public. He serves as the president of European Lifestyle Medicine Council and chairman of the World Lifestyle Medicine Council, as I stated earlier. So with that brief introduction, please join me in welcoming Dr. Lawson. Dr. Lawson, thank you so much for taking the time to be with us this evening. And the virtual podium is entirely yours. Thank you.
Well, from rather cold and windy Edinburgh in Scotland, a warm welcome and thank you to Dr. Ravi Mamtani and the organizers of this Cornell's Population Health and Wellbeing series. Thank you for your kind invitation to speak with you today. Hello to everyone and wishing you all well. So hopefully you're seeing the first slide. The it's really just a picture of your part of the world, and also to highlight where our next BSLM conference will be. So for this presentation, I should like to acknowledge at the onset the influence of Professor Gary Egger, who's Professor of Health Science at Southern Cross University in New South Wales, in Australia. He's recognized as a world authority on obesity and is one of the founding fathers of lifestyle medicine. Now, they say hope springs eternal. So there's just a reminder that in the midst of the current COVID unknown, there's always hope around us. In this case, a mountain called Hope is in the far distance in the county of Sutherland in Scotland. Now, today's presentation is not about how we might fix things, but more about the upstream issues we really need to understand. Then, with that understanding, we can begin to think about how to fix them. So it's a look at lifestyle medicine through a wide focus lens, a sort of panorama. So please pick out the areas of interest for your self-learning, or maybe even simply pick out topic headings for future meetings. The PDF of slides and references will be available to you if you want them, so don't try to read them all. Some slides are really far too busy for that. It's the overall impression of lifestyle medicine which you take away with you that really counts. Now, in 1975, the year I qualified, Ivan Illich had this to say in his Limits to Medicine: the medical establishment has become a major threat to health. So that was quite a welcome for me. And then a fast forward 39 years later, in 2011, the year I retired from National Health Service family practice, Gilbert Welsh et al. Had this to say: advances in medicine have made the impossible possible, but an over-reliance on healthcare threatens to bankrupt the world and make us all sick. So sadly, it seems as if I contributed to making everyone sick. And that's definitely not why I went into medicine. So along the way, something has gone wrong. Incidentally, just for your information, Gilbert Welsh has a publication, Less Medicine, More Health, 7 Assumptions That Drive Too Much Medical Care. It's well worth a read. And sure enough, in conventional medicine, we do have a tendency to overdiagnose and overtreat, judging by these figures presented and referenced here. Now, the last reference to near normal cholesterol levels, people may be on drugs for life with no benefits. I actually can't find my reference, but I think it's in the ballpark. Now, I just wanted to give you a little illustration. It's a real life story. A male patient, age 50, married, 8-year-old daughter, employed, and in September 2010, he was diagnosed with late-stage neuroendocrine tumor, which was thought to be pancreatic, and with extensive liver metastases. They were really rather large. They were unresectable tumors. They were poorly differentiated. The Ki-67 indicator was at its highest value of 30%. Palliative chemotherapy, after 2 cycles, had been unsuccessful, and other planned cycles had been cancelled, i.e., this man was effectively given no hope. And I was asked by his oncologist to inform the patient that he would be dead by, as it happens, the Christmas season, that is, in a matter of 6 weeks. And now to fast forward. Well, in 2022 now, he is entirely disease-free. So, and what this man had was a determination to live. He had the lifestyle medicine tools he chose to achieve his goal, included tailored conventional chemotherapy, albeit he forced the oncologist to reconsider the initial therapy. He had a knowledge of foods to fight cancer. He was taking regular physical activity. He was avoiding toxic substances, and he had the loving support of his family. So the challenge we face is not only to prevent disease in the first place, but to manage disease effectively, which means, in other words, holistically, which means a whole person approach. And this is lifestyle medicine at work, and a healthy lifespan is a primary goal. Why don't we even call it salutogenesis or health creation? Now, turning to life expectancy and disease-free life expectancy, the figures demonstrate that boys born in 2012 in the UK anyway, will have a lesser healthy life expectancy than their parents. Now, this is for the first time since records began, and latest figures now confirm that it is the same for girls. Incidentally, obesity alone costs £16 billion to the UK economy and a £4.2 billion cost to the NHS. Allegedly, 40% of the UK population will be classed as obese by 2030. And I understand in Qatar, 40% of adults are already classed as being obese. So what a legacy for our generation to leave behind. And COVID, by the way, has cost the UK in excess of 370 billion so far. If only a fraction had been spent on preventing ill health, would be in the same situation as we are now, I wonder. Now, shown another way, your eye is drawn to the right side of this chart, where you'll find the UK has slipped into the negative when it comes to difference in healthy life years between 2000 and 816. So things are moving in the wrong direction. This slide is really just to demonstrate that deprivation has a large negative impact on healthy life expectancy and can't be ignored. You can clearly see, again, on the right side of this chart, the widened gap in deprived deciles between the most and least deprived. Now, some risk factors are modifiable. And in the UK and Scotland in particular, 98% of us live with a key behavioral risk factor as listed. And 60% of us live with 3 or more risk factors. So why is lifestyle important? I mainly want to make the point here that although behavioral change is key, lifestyle medicine is not a blame game. We have to create the living conditions and environment for a healthy lifespan and make healthier living easier. So it's definitely not just in the genes, although epigenes can and do play a part. It's also worth noting that medical care has only a 10% impact on health outcomes. So here are some of the problems brought along by population living with long-term conditions, or NCDs, in the UK. So with 3 or more LTCs, we think there's 2.9 million people. 50% of GP appointments, that's a family doctor appointments, are made up from people with self-reported long-term conditions. Outpatient hospital appointments, 64%. Inpatient hospital bed day, 70%. Huge cost to the taxpayer, and cost of prescribed medications in 2019 was £20 billion. So with so many people affected, it is easier to understand why it results in considerable strain on our healthcare system and, of course, the taxpayer. If we decide to, we can do something about this. In fact, we have to do something differently to reduce this demand. And so the lifestyle as medicine first approach is that something which makes the difference. Here we have the temporal trends in disease epidemiology. There's another reason for us to be acting differently. Look what's actually arrived. We can see that thanks to public health measures, we had seemed to get on top of acute infectious diseases through better hygiene, sanitation, clean water supplies, and so on. Meanwhile, NCDs have been steadily rising across the timeline. In the UK, we're already past the epidemiological crossover point, and developing countries are fast approaching it. And as the arrows show, this syndemic or confluence of pandemics has now arrived, and it will inevitably repeat itself unless we bring in mitigating plans. So, metaphorically, let's get onto our bikes and to move into sunnier and healthier territory. Now, here's a definition of lifestyle medicine. The key here is addressing the underlying causes of NCDs. Another way of thinking about this is the rather cliched dripping tap analogy. The tap is dripping into a basin of water, the basin overflows, and as healthcare workers, we are the ones mopping up the spillage. But who, I ask, is turning off the tap? And who is removing the plug from the sink? Could it possibly be down to us and by utilizing lifestyle medicine approach? I like to think it is. Now, when it comes to risk, as you'd expect, lifestyle medicine sits as a mainstream, low-risk approach dealing with lifestyle, which is a cause and cure of up to 80% of our chronic diseases. Now, it is also evidence-based, science-informed approach, sitting firmly at the base of the evidence triangle. Now, we have to ask ourselves, fundamentally, as individual healthcare workers, where do we sit on this illness-wellness continuum? The treatment paradigm or the wellness paradigm? And it's sometimes worth reminding ourselves why we went into the healthcare industry in the first place. Turning now to the hierarchy of drivers of modern disease. Where does lifestyle medicine fit? Think of it as a stretched elastic band pulling together conventional medicine and public health. I have heard lifestyle medicine described as the clinical arm of public health, but also as the public health arm of conventional medicine. And here you can see the hierarchy of drivers of modern disease. The principal thing to note is that lifestyle medicine is about recognizing the upstream causes of most of the 21st century chronic diseases, as well as preventing, managing, and reversing or remitting disease. So whereas nutrition and activity represent the penicillin of lifestyle medicine, shall we say, psychology and behavioral change represent the surgery of lifestyle medicine. You'll see that obesity here is characterized not as a disease, but as a marker, the canary in the coal mine, as Prof. Egger has described it. So let's now go upstream using diabetes as an example. Diabetes is associated with obesity, which is associated with overnutrition and inactivity. And these may be associated with stress, anxiety, or depression, which may be associated with unemployment or housing issues. So if we concentrate only on disease, we're missing the target and arguably missing the point as well. So moving now to get an understanding of the components of lifestyle medicine. Firstly, the knowledge or the science. This encompasses the lifestyle and environmental determinants of chronic disease where metabolic inflammation is the driver. Secondly, the skills or the art. This means the skills and practices for changing unhealthy lifestyles and environments. Coaching, coaxing, boosting, and nudging healthier choices, and the change from extrinsic motivation to intrinsic motivation. These are all very important skills to possess. Also, of course, we need the skills in diagnosis, prescription, deprescription, and counseling. Thirdly, the tools, where the patient is an active collaborator. And this refers to tests or devices or equipment which can be used to assist changes towards a healthy lifestyle and healthy environment. It includes mHealth, for example, SMS text prompts, telemetry, ambulatory monitoring, implantable devices, self-monitoring, brief assessments, and internet connections, and so on. And finally, the processes, the sequence of steps needed to be taken to establish a course of action to improve unhealthy lifestyles or unhealthy environments. Of prime importance is facilitated self-management training, by which I mean active participation by people in their own care. Now, examples include group consultation, which is currently in a virtual format, or total telephone triaging, or social prescribing. Incidentally, the group consultation approach, with plenty of evidence behind it, gets health providers out of their silos into a brighter new world, together and engaged. Now let's look at the science first. Is there a chronic disease germ which lies behind chronic diseases? In 2006, Professor Hotta Mushlegil in Harvard and a speaker at our BSM 2021 conference published his research into metabolic inflammation, or metaflammation as it is known, which is the driver of chronic diseases in the 21st century. Now, just a reminder here of the cardinal signs of inflammation. I don't know whether you were taught in Latin or not, or whether it still is taught, but certainly I was. And I was taught as calor, rubor, tumor, dolor, and loss of function, which I could never remember. Now, here's a representation of classical acute versus modern chronic response. Most of us have experienced the burning sensation of an acute throat infection, and of course our immune system kicks in and we return to basal homeostasis. Metaflammation, on the other hand, has no microbial antigen and is often unresolved at a lower level of systemic inflammation. So these are burning embers, if you like. The inducers appear to be lifestyle and environmental factors, and the outcome is dysmetabolism and ultimately chronic disease. So in the light of what I've just said, looking at this slide, where would you expect to see chronic inflammation? I know the writing is rather small, so you may not be able to read the options, but coronary heart disease, hypertension, obesity are all first in people's minds. Well, actually, it's here. It's all over the place. Palliative care and I think epilepsy are exempt. And just as a reminder, you don't need it, but it is also a caveat, and you know this well, we're complex biological beings with loads of biofeedback. So linear relationships are in fact rare in medicine, but not unheard of. There are two categories of disease and multiple causes. So to hark back to that acute versus chronic inflammation, take a look at this slide. In 1673, while using a homemade microscope, Leeuwen Hoek discovered red blood cells and microscopic living creatures. And the scientific community just simply ignored him. And it was fully 166 years later before the involvement of these living creatures in putrefaction was finally accepted. And we moved on to accept the germ theory of infectious diseases. So things don't move quickly in science, do they? Indeed, Max Planck famously said that science advanced only at the rate of one funeral at a time. Meanwhile, as previously mentioned, in 2006, Professor Hotta Mushlegil discovered the process of metabolic inflammation, the slow burn of oxidative stress and chronic inflammation causing dysmetabolism and allostasis due to lifestyle and environmental inducers. Now, Professor Gary Yeager has called these inducers anthropogens. These are man-made and therefore can be man-unmade. Incidentally, he also coined the word obesogenic, which we all use nowadays, but anthropogen hasn't quite yet caught on in the same way. So you can see that the equivalent of hygiene and public health with acute IDs is lifestyle, medicine, public health, and environmental modifications. Now, here are determinants of disease and the metabolic inflammatory process. It's very busy, don't try to remember it. But if you pick out the first letter of each entry, it spells out the acronym NASTY odors. The levels of evidence for metabolic inflammation for each of the determinants is represented by asterisks. So we'll visit each one of them briefly soon. And at the foot of the slide, you'll see malaise. So don't forget adverse childhood experiences. You can see how broad now, or panoramic, is the lifestyle medicine brush, and how difficult it is to even begin the conversation with our patients in a short 10-minute appointment, as we have in the UK. Now, just to repeat, relationships in medicine are rarely linear. While we know about feet, forks, and fingers, look what's going on underneath. And of course, there's also importantly stress, sleep, and social relationships to consider. In terms of skills, we've labored a bit with the science, so quickly let's cut through to the other components of lifestyle medicine. Here we have the skills we need to embrace to enable behavioral change. And these aren't just words, they really are skills we need to develop. And it goes from the coaching, coaxing, boosting, and nudging that I mentioned already, motivational interviewing, counseling, prescribing, deprescribing, and personalized care, not forgetting shared decision making. In terms of the tools we need, these are them. My personal favorite, because it underlines the simplicity of our low-tech lifestyle medicine approach, is a piece of string for the strength test. And another favorite is measurement of visceral adipose tissue by bioelectrical impedance analysis. Simple walking speed and grip strength testing are also important and very easy to do tests and tools. In terms of the process, well, as I mentioned at BSLM, we promote group consultations, but that is a whole new presentation, and there's plenty of material on our BSM website. It's strongly recommended to bring smiles back to family practice and to secondary care too, of course. Now, what follows is a warning. It's the arty bit, as I call it. I'm using mainly pictorial representations of the determinants or the anthropogens, which will be handy for those of you who, like me, may be visual learners. So first up is nutrition. Overnutrition and undernutrition are two sides of the same coin. Both result in malnutrition. And to complicate matters, we can be metabolically healthy whether we are fat or thin. As we know, there's the footy, or fat on the outside, thin on the inside, and the tofu, thin on the outside, fat on the inside. So these are examples. Food, of course, is a hot topic and also mired in controversy. Interesting, Wendell Berry, farmer, essayist, and writer and activist, said this about the food industry, and I'll let you read it. And this about the health industry. So tragically true. Now, this is our current trajectory. So how did we get here? So let me give you an example. What on earth is this queue about? It's several hundred yards long. It's in a shopping mall in Melbourne, Australia, as it happens. But curiosity got the better of me. So I walked down to the head of the queue. And this is what it was about: free donuts. Now, to continue the donut theme, what do you suppose this list represents? So it's biscuits all the way through to 150 fizzy drinks. Well, you guessed it. It's the average yearly consumption of a child in the UK. Just to get back to nutrition, and Montero defined 3 levels of food and drink. Whole foods, relatively unprocessed. Substances extracted from whole foods. And ultra-processed foods and drinks. Now, generally speaking, the pro-inflammatory values are being exhibited by modernized foods, and the good anti-inflammatory values from whole foods, to which humans have adapted over several millennia. On the subject of ultra-processed foods, as a percentage of household purchases, you probably don't need to guess which country in Europe tops the list. I could not find a figure for Qatar, but I wonder if I should mention the French paradox here by looking across the channel, which stands at 14.2% in comparison to UK at 50.7%. So France being a country where cardio and cerebrovascular disease is certainly much lower compared to the UK. Now we're going to speed up. Physical activity. Inactivity or lack of sufficient activity is one of the most underappreciated causes of long-term disease. We don't need to be active these days, probably the first generation in history for which some level of activity has not been a daily requirement. And here's some stats indicating how physical activity reduces risk of mortality and morbidity. If this was describing the impact of a pill, would you take it or advise your patients to take it? Rather ridiculously, I'm terrified of being bitten by a shark or a snake. But frankly, my attention should be elsewhere, as you can see. Physical inactivity, smoking, and mosquitoes wreak havoc in a health sense. And here's why we're less active. And by the way, it's okay to blame us Scots for the 30% reduction in daily energy expenditure. As inventors of the telephone, the television, refrigerators, and probably the remote control button for the television set too, we're a nation of couch potatoes. We also know that screen time in children has been strongly associated with overweight and obesity. So we really do need to think differently and view movement as an opportunity, not an inconvenience. Here, I just wanted to illustrate that low cardiorespiratory fitness contributes more to population deaths than diabetes, obesity, and smoking combined. Something to stop and think about, isn't it? Here's one of the barriers. It's that remote control and television again. And of course, computer screens such as this. So, my apologies. Which egg are you? Stress or strain, anxiety, and depression? Which egg are you? The guy on the right, by the way, is my family doctor. Now, stress, which is endemic to humanity, has more recently become a chronic strain on our physiological adaptation. The outcome, as described by Arthur Roach, is a thin stream of fear trickling to the mind. If encouraged, it cuts a channel into which all other thoughts are drained. How elegantly put. And of course, as a consequence from this channel, a whole range of long-term diseases are born. And strategies for preventing and dealing with stress are a comprehensive cornerstone of lifestyle medicine. How many of us here have suffered the colorful parts of this slide? Quite a few, I imagine. And I suspect we have very individual tales to tell about how we have coped or not, especially in the time of the coronavirus epidemic. Now, the technological age of the late 20th century, or the Anthropocene era as it is now known, has brought with it new challenges, including the ill effects of certain forms of modern technology. At extremes, it involves mortality from high-tech warfare or even transport accidents to computer-related problems such as impaired vision, repetitive strain injury, neck and back problems, and skin problems, even so-called Facebook depression. At an extreme, improved agricultural technology, such as hydroponics, is leading to excessive toxicity of recreational drugs. Inadequate sleep. Along with inactivity, inadequate sleep is one of the most underrated lifestyle risk factors for long-term disease. It's the amount of good sleep that is important, and how you spend in your bed. So modern lifestyles are in direct competition with sleep. Arguably, the majority of modern sleep problems have a basis in our lifestyle choices. And you may have heard recently that many of our kids are chronically sleep deprived, not helped by the quantity of screen time. Additionally, if you suffer a long-term condition, then sleep quality may be affected, creating a bidirectional vicious cycle, a situation commonly encountered in lifestyle medicine. However, with a healthy approach to lifestyle and attention to sleep hygiene, things can and do improve dramatically. Environmental influences come from various directions. For example, making unhealthy choices in an obesogenic environment, or being exposed to endocrine disrupting chemicals and pollutants in the air, water, and soil. Now, we're all exposed to these environments, yet we know so little about them. An endocrine disruptor is defined as an exogenous substance or mixture that alters functions of the endocrine system and consequently causes adverse health effects in an intact organism or its progeny or subpopulations. Many endocrine-related diseases and disorders are on the rise. Large proportions, up to 40% of young men in some countries have low semen quality, which clearly reduces their ability to father children. Global rates of endocrine-related cancers, breast, endometrial, ovarian, prostate, testicular, thyroid, have been increasing over the past 40 to 50 years. New chemicals are registered every 2.6 seconds, and more than 80,000 are toxic. The WHO list of known EDCs is a long one, yet very few have been properly evaluated. The cocktail effect is completely unknown, nor is the impact of long-term exposure to very small amounts of these toxins. We know that some constituents of dermatological products are carcinogenic, and others reduce fertility. A horrendous fact is that cord blood of newborn babies may contain up to 200 man-made chemicals known as forever chemicals. COPD and dementia have been in the news as being linked to particulate matter. Just note here that COPD deaths from household air pollution is double that of ambient air pollution, something we don't hear much about. We've been concentrating on outdoor pollution, which appears to have a lesser threat for NCT death, so worth thinking about. When it comes to environmental pesticides, a bit of fun. Which list contains your favorite, the Dirty Dozen or the Clean 15? Incidentally, imazalil, a fungicide that can change hormone levels and is classified by the Environmental Protection Agency as a likely human carcinogen, was detected on nearly 90% of citrus samples tested by the EWG in 2020, and on over 95% of tangerine samples tested by the USDA in 2019. So pesticides may be a small contributor to our risky lives, but one we should care about. On a separate but topical note, of course, there's public health risk from climate change to think about. Meanwhile, the environment, or microbiome, we're a long way from being able to prove causality, but there is an association between unhealthy leaky gut, unhealthy immune systems, and disordered brain functions, the so-called gut-brain axis. We know that a healthy diet, as well as sleep and physical activity, will heavily influence our microbiome. The answer to the question, by the way, is a child's plastic duck in a bath. a bit of useless information. But I certainly used plastic ducks in my kids when they were small. Now, this is meaninglessness. We're coming to the malice bit of Gary Egger's acronym. Meaninglessness or learned helplessness. Some have suggested that the reason Glasgow, Scotland's biggest city, has a worse health record than comparable cities in the UK is down to this, possibly due to sustained high cortisol levels as a consequence of intergenerational epigenetic changes. In other words, nothing to do with money or blood pressure, cholesterol levels, or statins. Alienation is associated with metabolic inflammation. Who would have thought? Now, here's a quote I want to share with you from Jimmy Reid, 1972, as rector of Glasgow University. Let me at the onset define what I mean by alienation. It is a cry of men who feel themselves the victims of blind economic forces beyond their control. It's a frustration of ordinary people excluded from the processes of decision-making. It's a feeling of despair and hopelessness that pervades people who feel with justification that they have no real say in shaping or determining their own destinies. This is such a powerful statement, isn't it? In terms of loss of culture, an example is the indigenous people of Australia who have 30,000 years of history. A good, or is it a bad example? Their whole way of life has been disrupted by incomers to the extent they're now amongst the unhealthiest in their country. Until the pandemic hit us, some people were determined to turn up for work no matter what. Occupational status and employment type, such as shift work, may have direct effects on health and safety. But social factors, such as perceived social injustice, burnout, security of employment, all play an increasing part. Both physical and psychological occupational environments need to be considered as part of a lifestyle perspective on health, as described by Professor Michael Marmot. He describes high demand and low control, imbalance between effort and rewards, social isolation, organizational injustice, job insecurity, and shift work, all as a toxic cocktail. Now, cigarettes and recreational drugs have adverse effects, so who knew? Pharmaceutical products often have ill effects as well. Now, iatrogenic deaths are third on the list of deaths in the US and probably in the UK too. It is estimated in the UK that up to 1 million people are admitted to hospital each year due to prescribed drugs and cause 10,000 deaths. Now, the art of lifestyle medicine is to provide a lifestyle approach to health management and deliver optimal health outcomes. So sensible prescribing, de-prescribing where possible, patient engagement and long-term disease management is a logical approach. For example, in one doctor's practice in Southport, England, diabetes has been reversed. Patients are coming off medication and the practice has saved the taxpayer £50,000. Can be done, should be done. Well, when it comes to toxic substances, clearly smoking and alcohol, they have social costs as well as physical ones when taken to excess. A few lifestyle-related behaviors, such as smoking, have a linear association with ill health. Others have a U-shaped or tick-shaped association. And exposure to certain forms of UV light is a case in point. Too much sunlight may be a cancer risk. Too little can result in vitamin D deficiency. And the latter is associated with a host of health problems, probably because it acts more like a hormone than a vitamin. We're seeing children once again developing rickets due to sedentary indoor life. And yes, even now there's still asbestos about. And yes, there needs to be more fun ahead. Now, poor social relationships have been linked with the inflammatory process, probably by association through the hypothalamic pituitary adrenal axis. Loneliness has risk, which is likened to smoking risk, and lack of social support is also an issue. So the lifestyle medicine practitioner may also need to be part relationship counselor, or at least have referral networks into which to refer. And just to illustrate the point, here's a comparison of odds of decreased mortality across several mortality-associated conditions. Social relationships really do matter. Look at drug treatment for hypertension near the foot of the chart and the top three, all social relationships. Now, social disadvantage, it's recognized that income inequality, financial employment-related insecurity are established health risks. And absolute poverty appears to be less of a concern than relative poverty. And metabolic inflammation has been shown to play an intermediary role here. As clinicians, should we be acknowledging this more, maybe? This is just to illustrate the income inequality versus index of health and social problems. The lower the income inequality, the better the index of health. And you can see the UK and the USA at the wrong end of the scale, while Japan and Nordic countries are at the better end. The longevity study from the Western USA, started by Dr. Charman in the 1940s and followed up 40 years after his death, and also the Harvard study of adult development, still ongoing after 70 years, concluded that healthy longevity was dependent on having a purpose in life and a strong relationship with someone trustworthy. Interestingly, conscientiousness was a common characteristic, as was being involved in the local community. Moving on to a global perspective, as we come to the end of this presentation, can I bring a perspective just for you to look at? Here is the burden of disease by cause in 2017. And you will note that the blue bars relate to avoidable NCDs. The lifestyle medicine approach really does have the potential to avoid premature deaths in huge numbers. Simply reducing central adiposity and smoking could result in preventing 140 million years of lives lost. Staggering. So, having traveled along the top route, we now have to travel down the bottom route, get our nations back to optimal health. How do we do this? By working hard on the modifiable determinants of health as listed here, and the less modifiable ones too. We need to fix things. So the modifiable ones, mainly plants, not only plants. Make sure we're active, maintain a low stress life, excellent sleep, control our drug and alcohol use, and good social support. So these are the solutions for you to put into practice, and the ones which BSLM is working hard on, principally through certification with the International Board of Lifestyle Medicine, and also through our BSLM Learning Academy. Now, to help us along the way, I've slightly adapted the US Patient-Centered Outcome Research Institute's key questions for research grant applications. Odd, perhaps, but I felt very relevant. So if these questions could be answered at a personal level, at community level, at national level, and at global level, then we should be doing a great thing and going a long way to achieving the goals of lifestyle medicine and achieving a healthy lifespan for the planet's human occupants. So just to end now with a quote, our prime purpose in life is to help others. And if you can't help others, don't hurt them. Ladies and gentlemen, thank you. And I hope at some point your interest was piqued. And I do hope you have identified some takeaways. And I'm happy to field questions in due course. Naturally, you won't be surprised to learn I'm completely biased about lifestyle as medicine. Now, I'm going to try to stop sharing, and who knows, maybe even get myself back into the picture if I'm lucky. And oh, here I am. So really, I just want to say thank you so much for paying attention. Thank you very much indeed for inviting me once again. I do hope that I can be there live, sort of, and join in some of your fun. But thank you very much indeed again, and hopefully we'll see you soon. Bye-bye just now.
Well, Dr. Lawson, that was a fantastic discussion on lifestyle medicine. And you did it so well, that it not only raises questions in minds of practitioners, but it provides guidance to move in the direction that would be helpful to the people around the world. So thank you so much.